Hello, my name is David Armstrong, and I'm the director of the Health Workforce Tactical Assistance Center. Today's event is entitled Artificial Intelligence's Role in Reshaping the Future of Health Workforce, Solution or Disruption. Now, with that said, I'm going to go ahead and introduce you to today's guest moderator. Today, Xiaochu Hu, a research manager at the Health Workforce Studies Group at the Association of American Medical Colleges, who is also the chair of the Health Workforce Interest Group Advisory Committee at Academy Health, will be leading off and moderating our event. Xiaochu?
Thanks, David. Hello, everyone. My name is Xiaochu Hu. I'm a research manager at the AAMC, and I'm also the chair for the Academy Health Workforce Interest Group. I'm going to say a little bit about our IG, the interest group. We are one of the 19 interest groups at the Academy Health. Our mission is to improve health and healthcare by promoting research and disseminating evidence that informs health workforce policy and practice. You can join our IG when you join the Academy Health. From there, you can use the listserv to share information. Please contact me or our Vice Chair, Debbie Goldberg, for more information about the IG. Our interest group organizes free webinars throughout the year. So thanks to the Health Workforce Technical Assistance Center. The next one will be next week on the retention of the nursing workforce. Well, if you are attending Academy Health annual research meeting in Minneapolis next month, please also mark your calendar for our IG session on the workforce caring for an aging population. We also co-host a happy hour social event, and here is the RSVP link. Today, we're thrilled to have two outstanding speakers with us who bring their deep expertise in the topic of how AI can help shape our workforce in the future. The Dr. Shira Fischer is a senior physician policy researcher at the RAND Corporation, where she focuses on health information technology and AI in healthcare and medicine. She founded the RAND's Digital Health Strategy Group and led it for almost a decade. We also have Dr. Jonathan Cantor, who is a policy researcher at the RAND Corporation and also a professor of policy analysis at the RAND School of Public Policy. His research focuses on health policies related to mental health, substance use, and health behaviors. Shira and Jonathan, we're excited to hear from you. Take it away.
Hi, everybody. We're so glad to be here. Thank you for inviting us to speak. We were really pleased to meet Xiaochu at a RAND workforce webinar earlier this year and had some great conversations. And that's how we've come to you. We're also happy to tell you about RAND if anybody has questions about where we work and the other kinds of work that we do. But today we're focusing, next slide, please, on the role of technology in the healthcare workforce and how AI is impacting the way people work in healthcare for good and for bad. Title, Artificial Intelligence's Role in Reshaping the Future Healthcare Workforce, Solution or Disruption. Click. I want to start with a basic principle, which is the fundamental theorem of informatics. This is something that I learned about early on in my informatics training, and I always come back to. When we think about using a computer versus a person, the dichotomy is really not like computer better than person or worse than person. That's not the way that I like to think about how technology can help us in general and specifically in healthcare. The question is not whether the computer alone is better, but instead how digital tools can improve human performance. So computer plus human, could that be better than the human? That's been the case with electronic records and decision support, and I think is a more useful way to frame AI and AI on workforce questions as well. Are there places where these tools can improve what we're doing now versus not having those tools, rather than thinking about replacement? So with that framing, I'm going to turn it over to my colleague, Jonathan Cantor, who will lead us through the beginning of this presentation.
Thank you, Shira. So I think as everyone here who's attending today knows, the COVID-19 pandemic has led to substantial changes to the healthcare industry and healthcare workforce. And so I'm going to give some context to where we're at now, prior to handing it back over to Shira to go describe where we're going. And so essentially, the COVID-19 pandemic caused a massive and unexpected shock to the healthcare sector. I'll draw people to this article by David Cutler if you want to get a better sense of like this holistic understanding of how healthcare was impacted from an economics perspective. So in terms of what happened immediately is that we saw, large declines in in-person visits to healthcare providers, with some offsetting by telemedicine. This is during early on in the pandemic, at least. So a lot of the work that I've done more recently has tried to look at and understand the healthcare workforce and what has occurred there since the pandemic occurred. So between 2019 and 2020, initial estimates were that we found that there was a 5.2% drop in total employment within the healthcare sector. We later revisited this work and found that we still had not recovered in terms of the full employment for within healthcare by the end of 2022. Just to show this visually, this is the non-healthcare workforce between 2016 and 2022. The blue line in the vertical blue line is when the COVID-19 pandemic occurred. The yellow dots are what we expected to have happened had there been no pandemic. And the blue dots show what did actually happen. And you'll note that there is some overlap between the yellow and blue lines by 2022, indicating that at least for the non-healthcare workforce, that there was recovery. This is what it looks like for the healthcare workforce in panel B. There you see that both the yellow dots and the blue dots are not overlapping by the end of 2022. This indicates the fact that we did not fully recover in terms of the healthcare workforce. We have since revisited these analyses. We expect that work to be released later this month or in the next couple of months at JAMA, and it will give you a better sense of where we're at as of 2024 now. So healthcare workforce shortages are both important, but they're also the causes of which are complex. So shortages can contribute to a myriad of factors: lack of access to care, inappropriate delivery of care, high treatment costs, and worse health outcomes. While the causes of such shortages, those include the reduced retention of physicians, higher rates of burnout, aging physician populations, and high educational costs. These are familiar to folks. It's mostly because, at least for the causes, I took them from work by the Association of the American Medical Colleges. This is from a recent report that was released that shows that by 2036, we expect there to be a shortfall of physicians between 13,500 and 86,000. I want to also just make sure that I highlight this other brand new, as of last week, research article in the Journal of General Internal Medicine that basically describes the fact that there are these two different ways of projecting the total shortage of physicians in the United States. The HRSA piece projects, as you can see here, up to 187,130 by 2037, whereas the AAMC one does a slightly different number. And I think the main point, at least, of this article is the fact that it doesn't really matter the magnitude, the differences, or how we get to these actual specific shortfalls. What's most important is the fact that there is a shortfall, that it is coming, that it might disproportionately impact non-metro areas and in primary care disciplines, and that we have to act. Just so that we can give you a flavor of other parts of the healthcare sector that we also see shortages in. This is from the American Hospital Association, or AHA, that they expect a shortage of about 100,000 critical healthcare workers by 2028. They expect that the shortage of nurse assistants may be severe. The gaps may differ widely by state on registered nurse availability, that there's a modest surplus of physicians expected nationally, and that compensation variation could lead some workers to move. So somewhat more encouraging numbers, but I also wanted to draw attention to the fact that I believe earlier this month or just recently that this new paper, this news research letter came out, basically identifying, projecting the number of hospital bed shortages that the US is expected to encounter over the coming years, and basically finds that we're going to be reaching about 85% capacity in hospital beds by, I think, 2032, which is very concerning. And that, this is mostly that we've seen a decline in full-time employees, and then also that we've seen at least more hospitalizations since the pandemic. So this is mostly just to highlight the fact that even if we do see workforce encouraging numbers within particular sectors, that there could be other issues as well, and that we really need to look at everything holistically. In terms of allied health shortages, the National Center for Health Workforce Analysis projects that we're going to be seeing by 2037 some shortages in dispensing opticians, respiratory therapists, physical therapists, pharmacists, podiatrists, and chiropractors. So again, shortages here. In an area I'm more familiar with as well, behavioral healthcare, there were substantial shortages prior to the pandemic, and that there were giant geographic disparities in access to providers prior to the pandemic. And there's a large concern about how both during the pandemic and then after the pandemic, what will occur. But again, estimates from the National Center for Health Workforce Analysis found that by 2037, that we're going to have shortages in addiction counselors, mental health counselors, psychologists, psychiatrists, marriage and family therapists, and school counselors. Again, so this is just to mostly say that we're having problems in multitudes of areas, and that we're going to have to be aggressive in terms of how we actually handle this, while also being cognizant of the fact that we're going to have to handle and address other areas as well. This is basically a heat map that shows areas of the country that have a practicing child and adolescent psychiatrist. Now, it's a lot of colors, but what I really want to actually highlight the fact is that the red areas, for example, are specifically areas where we're lacking child and adolescent psychiatrists. And you'll see that, a wide swath of the US has that issue. And so about 72% of counties lack a child and adolescent psychiatrist. So again, this kind of really shows you the fact that, like, when we think about healthcare workforce, even if we do focus on psychiatrists, we also have to consider, child and adolescent psychiatrists as well, and just really gets at the complexity of the problem. So why was the healthcare workforce uniquely impacted by the COVID-19 pandemic? I think a lot of folks, there's been a ton of research in this space, and I think it's going to be ongoing even with the conclusion of the public health emergency. That you'll see a lot of the studies that I mentioned here are actually still ongoing or have been recently published. And so what we initially found was that there was an increase in exit rates by healthcare workers that was offset by new hiring in 2021. Some really recent research has been kind of looking at one of the first groups of graduating residents, at least for New York, found that they were less likely to enter into rural communities and were less likely to report a good job market outlook. And some of the reasons that, at least during COVID, that the healthcare workforce was disproportionately impacted include the fact that, emotional exhaustion was really, increasing a lot, and that there was higher levels of stress and burnout in both clinical and non-clinical staff. And we know that burnout, even prior to the pandemic, is just a very important area of concern. I think there were also a lot of anecdotal, but as well as just, further research that's been done that looks at, threats of violence against local public health officials and concerns of threats of violence against healthcare workers. And I think this is going to be an area of research that folks are going to be focusing on a lot in the future about, what are the downstream impacts of this as well, in terms of both, threats of violence and actual acts of violence on healthcare delivery. So I now want to kind of shift gears and kind of discuss the fact that, the COVID-19 pandemic led to evolving and ongoing changes in how care is delivered, right? So the big thing that, I had mentioned earlier was the fact that we saw this huge drop in office care, and that was partially offset by telemedicine. There was just this real concern that we were going to overburden hospitals, or that, we needed to make sure the fact that we didn't have people coming in for non-emergent care or for preventative care. And so, shelter-in-place laws were also in effect. There were school closures. There were a myriad of factors. And so, it really led to this giant increase in telemedicine, right? It was this huge opportunity. And so, within the rise of telemedicine, we found that it wasn't experienced the same across all geographies, payers, conditions. Some of the work I've done found that there were differences by urbanicity, and then, broadband. Other work done by Nakamoto, for example, looked at differences by the types of providers. And then, Walker et al. Just recently had a study where within the substance use disorder treatment space, that there were differences by payer. And again, all of this is very complicated. And difficult given that there are multiple things going on during the pandemic, as well as just differences in the data side as well. We also found that, even without the claims data focus, that there were differences in state telehealth policies and how providers responded. So some of the work that we did found that state policies could encourage the offering of telehealth by substance use disorder treatment facilities. I think Lucinda Leong, I'm giving a shout out to as well, has been doing a lot of work trying to identify state telehealth policies in a holistic manner. That'd be really helpful to understand what happened during the pandemic. A lot of folks are focused on the federal policy changes, but I still think we're only getting a handle on the state telehealth policies. And I am not sure if people know this, but the federal telemedicine policy was supposed to be for Medicare waivers, was set to expire the end of March of 2025. I checked this morning, and now it's going to be pushed all the way out to September 2025. So, there's ongoing conversations going. So I just wanted to give you a flavor of what happened during the pandemic, just so that you're able to understand, what is the state of things for new and emerging technologies now. So I think that, this New England Journal of Medicine article by Atib Malhotra and Lori Usher Pines does a really good job of listing what do we know and then what do we need to know in terms of telemedicine. Because, this was like a very transformative technology as we're entering into a space where artificial intelligence is becoming more used. So the three big questions are, what is the impact of telemedicine on spending, patient outcomes, and health equity? Having worked on all three of these spaces in ongoing work, even just trying to catch up with the pandemic, this is really hard in the sense that claims data is lagged. It's hard to get measurements. It's hard to actually identify the effect of a lot of these policies. And then even then, the impact of delivery on care. And so the challenges here are that, there are different studies contain different samples by payer, condition, geography, and provider. So, even the fact that we've had telemedicine for so long, or what seems so long now, we're still doing work. So I still have papers that are ongoing on trying to get the causal impact of the introduction of telemedicine on total healthcare spending. And I know other groups are working on patient outcomes and health equity. So we still haven't even reached the point where we know what's happening in telemedicine. Of course, I'm saying that now and then shifting drastically to artificial intelligence. And so, we don't really have great data on AI use. And so I think, one thing that I tried doing before this talk and the previous version of this talk was to be like, what is going on with AI? And so, surprisingly enough, the census does have this really good data set called the Business Trends and Outlook Survey, in which they collect data about whether or not you've used artificial intelligence in the past 2 weeks in producing goods or services. While it's not the best question for healthcare, and arguably, it's hard to identify healthcare sector within the actual data, you can see that there has been some rise between 2023 and 2025. So we're seeing about 7% of organizations within the healthcare sector are saying at least that they are using, artificial intelligence in producing goods or services in the past 2 weeks. Now, if you want to project out for the next 6 months, do you plan on using this? You see the numbers are not drastically much higher, that were about 11% since January 2025. This also led me to be like, well, what is going on now? And so I basically spent this morning trying to take a look at and seeing where we are at in terms of, since the last time the survey was out in January. And so these are the numbers, you recall, from September 2023 on the left. So about 4% said they used it in 2 weeks, and then 6% said they would use it in the next 6 months. Here's where we're at now with the most recent data, which I think was in April 2025. And you'll see here that we're at about 9% say that they've used it in the past 2 weeks, and about 12% planning on using it in the next 6 months. And all that to say is that we've seen over 100% growth between 2023 and 2025, but as you can see by the y-axis, this is to show that not everybody's using this. So there's a lot of measurement error here in who's using it, what they're using it for, but we are seeing growth. So large language models, this is the new hot trend. And so I tried finding on, a good medical definition for this. And so in JAMA, one of the articles they have what is a large language model? And they give you this text. So they're defined as that they learn the probabilities of occurrence of sequence of words from a corpus of text whose probabilities are learned using textual corpora with trillions of words such that the resulting model has billions of parameters. I like to just say that it can predict the next word or a series of words. That's just the best way that I can think of it. It's probably a lot more complicated than that, but that works for me. And so there's some epidemiological data that's looked at this. So about 40% of US individuals between 18 to 64 now report a routine use of LLMs. When we start focusing on healthcare, we find that back in February 2023, that about 78% of survey response said they were willing to use ChatGPT for self-diagnosis. And I think, an even more recent survey, again, a lot of this is all survey work, is that, adults under the age of 65 and those in households earning less than 50,000 are particularly likely to use LLMs about physical and mental health. So this is other work that we have ongoing that is close to being submitted, and it's about children and large language models for mental health. I think folks know the fact that we're in what the Surgeon General has called as a youth mental health crisis. And so we wanted to get a sense of who are using these models and if they are using this for behavioral healthcare purposes. And so these numbers have not been published. They're still in the works, but these are preliminary. So we did a nationally representative survey of about 1,000 adolescents and young adults between the ages of 12 and 21. We found that about 13% said they use LLMs for mental health advice. Of those that do, about 66% use them once a month or more frequently for mental health advice. And I think the most shocking number for us was the fact that about 93%. So they found that the advice they were getting was somewhat or very helpful. So this is kind of giving us a sense of this technology is here. People are using it for healthcare, even in the case of behavioral healthcare, and that they're liking the responses they're getting. And what, we have to think more about what the implications of this are in terms of healthcare delivery as, providers, researchers, and health services researchers. I'd also want to note the fact that about 50% of kids said they were using LLMs in general. So, this is a smaller percentage. I think it was around 20% of those that use LLMs said they were using for mental health advice. But, given the fact that, it is occurring, we expect it to increase. We also found that there was increased use for older aged adolescents. But, even now you're seeing that a lot of these models are being adjusted for anticipated use by kids. So I think Google has already changed the fact that they're going to maybe be their age restrictions now up to 13 now, or 13 or older. And then we also found that Black youths were less likely to report that the mental health advice as being helpful, which might get to cultural competency. So that's kind of giving you a flavor of things where it's at. And I think I'm going to pass over to Shira now.
Great. Thanks so much, Jonathan. So that was very helpful context about the healthcare workforce, COVID, and large language models. So now let's go to how this might affect the workforce when we look at actual clinical applications. So just to get a broad overview of AI use in healthcare, not from the individual level reporting, although that Jonathan just did, but from the hospital level. Next slide, please. We have some data from the American Hospital Association conducts a survey, and in 2022, only 1/5 of hospitals said they've adopted some form of AI. Now, just as Jonathan was pointing out, we want to clarify that it's kind of like machine learning or some of these terminologies. Obviously, they've been using risk models for a very long time, and there's predictive models and things like that. But the new thing coming on is this generative AI, the large language models. And so probably when these hospitals are saying that they're adopting some form of AI, they're not thinking about the sepsis risk models or things that they've been using for decades. But then in 2025, the same AHA survey shows us that 65% of hospitals are saying they're using predictive models that are based on AI. So not just risk models, but using AI-based tools. And 79% of those models are from their EHR developer. So they are not necessarily developing them locally, but they're using them. Only 44% reported local evaluation for bias, but they're using them because they're increasingly available to them. Next slide, please. So what are some kinds of examples where you might be using a large language model in medicine? Next slide. There's a lot of possibilities. So one paper, Klussman et al., describes some possible uses for LLMs in medicine. So let's go through those examples. In patient care, there's medical knowledge and documentation and voice to text. There's translation and summary, which can be very powerful in places where you don't have an immediate translator, you don't have text in every language. Patient empowerment. Then in education, this prompt engineering, critical thinking, personalized education, interactive learning. And then for research as well, there's a lot of potential: scientific text production, access to scientific knowledge, programming, and science communications. And we know that these LLMs do really well on medical tests. I mean, they have their abilities have increased significantly. So let's look at some specific use cases. There's both workforce or administrative kinds of use cases, and then there's more clinical use cases. So I want to go through a few examples. So one that has been used increasingly is drafting email responses. Like Jonathan said, there's a lot of burden on like the inbox for clinicians and having to answer email and increase use of the portal. So we can go through some use cases. People are starting to use AI to get a draft response to a patient portal message. So if somebody asks about their test results, it can draft up an email that says, "Hi, and it was nice to see you last week," or it can take information that it knows about prior visits and then put in the test results and then provide follow-up instructions, suggested replies for common questions that people ask to save the clinician time. These responses can be longer and more friendly than a clinician might generate if they're rushed and doing it. So some benefits. It can reduce clinician and staff time spent on routine, low-risk communication. It can enable faster response time. And what's the impact on the workforce? So again, the clerical burden on staff and on physicians could be less. And it could even allow medical assistants or scribes to answer some of these questions. The challenge or the risk is, of course, concern about accuracy. Also, if a physician is having to review every answer to make sure that it's correct, the time savings might be limited. And we'll get to the question shortly about what patients think about receiving messages that are signed by their doctor that maybe weren't completely written by their doctor. How do you communicate that, whether you want to communicate it with to them, and how patients feel about that? And last, yes, so then there may be new roles. So when we think about workforce, maybe it's reducing the number of jobs because people have fewer things to do, but it may actually increase new roles like an AI communication specialist or an inbox triage manager who's worrying about these, making sure that there's a workflow, that they're getting reviewed before they get to patients. So let's look at another example, scheduling. So that's another place where AI can come in. Maybe we can go through the animation. Yeah, sorry. I didn't realize these were fully animated. So the AI can match patients with clinicians based on availability. I go to a very high-tech hospital, but I still have to call. You can't just figure out what's available and get a slot. You think it would be easier. You can book other things that way. You can't book your appointments that way. So better ways of doing that: predictive modeling to reduce no-shows, optimizing slots. You can even have a conversation with an AI or a chatbot to schedule and confirm, and then you could cancel without having to make a phone call. And then dealing with wait lists, which is always an issue to make sure that cancellations are filled. So this could reduce wait time. This could, again, increase clinician productivity, have fewer unused slots. So again, similarly, what's the workforce impact? It's reducing burden on the front desk and the call center. So maybe it frees up time, and maybe then they can move to more complex tasks or focus on real patient interaction. On the other hand, there's always this risk of, if you're moving people to doing always higher burden work or more intense work, and they're not doing the simpler work, whether it's a physician or a front desk person, what does that do for burnout? And then it requires new oversight roles to manage and fine tune this. Is the right person scheduled for the right thing? Does the system take into account availability of wheelchair or, translator, what are the different kinds of access issues that are needed for that individual, and is it built into the system, or is it just in the scheduling nurse's head? Then there are more clinical types of uses. So radiology is one that's really very far ahead in this right now. In radiology, you can have a first read done by AI with automated detection of abnormalities, triage and prioritization of cases so that you see the more urgent things first. The radiologist gets the more urgent things first. There's image quality enhancement and reconstruction, which could even potentially make MRIs faster if they don't have to take as many pictures. So that really has an impact on patient experience and cost if you can get the same quality image. So benefits could be increased diagnostic accuracy and consistency, could be faster turnaround times, and maybe support in resource-limited settings where they don't have a radiologist or don't have a specialized radiologist. There's impact on workforce, so maybe radiologists are replaced. We don't know. Maybe they're not replaced, but they only read more complex things, or they get a first read. Again, we have this issue then of, do they stop learning how to read the simple stuff because it's getting taken care of by AI? Is the burden much higher? And shifts skill demand again towards AI literacy and oversight if you're just correcting an existing report versus generating it yourself. And what's the risk of just accepting in any of these cases what the AI suggests, and is that going to introduce errors? And one very interesting, I'm not sure whether to categorize this as clinical or administrative because it's some of both, but it's documentation, ambient documentation. I don't know if any of you have experienced this. I've seen it as a patient as well. Can we just record this and it'll help me generate my note? It's passive listening during clinical encounters. There's a number of companies that do this. It generates a structured note straight into the EHR. So a provider has their note finished. The physician already has an existing note when they finish the encounter. The idea is that it could learn provider preferences over time, that you don't need to, restructure so something that's mentioned at the end ends up in the right place. So the benefits include reducing clinician time spent on documentation, improves patient engagement. We've been talking for years about the issue of having the doctor looking at a screen and not at the patient, and asking the patient to clarify. So that goes right into the note and listening to what the patient says, not just what the provider says. It could enhance note quality and standardization. So for the workforce impact, again, it eases burnout and attrition among primary care doctors. It's not always clear what the errors are going to be. So we've argued, a colleague and I recently argued in an editorial that existing notes aren't that accurate. So there are problems in AI notes. There's certainly concern for hallucination. There's been, errors in names of medications and different kinds of things, missing out on social history components, but humans make mistakes also. We have plenty of notes that say left versus right, or I once was 6'3" because the person who was speaking had an accent, and then the next appointment I lost a foot of height. So if you just read people's actual notes, humans aren't perfect either. But are the kinds of mistakes systematically different that AI makes? So there's real questions about that. What does it focus on? Do people not learn to write notes? So there's that component of the education piece. And then someone recently wrote a very moving essay, I forgot her name, so I can share it, but about the story behind it. What about the personal component? If you just have the AI saying, what happened? Are you missing the personal connection? And as a PCP, she really thought that writing the note helped her to think about the total problem and what was going on for the person in front of her in order to treat them. So is it, depersonalizing? Now, there's also ethical issues. We'll get to that at the end, but ambient documentation is really spreading. People really do feel like it helps, like with timing, helps with burden, and the costs are little. So it remains to be seen if it saves a ton of time if people are then asked to see more patients rather than just having more time. So those are some clinical examples of how AI can be used. Now, what do patients and physicians think about all of this? So as part of a study funded by the National Institute for Healthcare Reform, colleagues of mine at RAND are talking to patients and providers about AI in healthcare. So this project is led by Dr. Zachary Predmore and Dr. Dmitry Kodakov. And we basically wanted to see if there was any consensus on these complex potential benefits and dangers of AI use in healthcare. So we did a mixed method study. We both asked patients and we asked providers. We put together a survey, and we also had an expert panel. So here are some of our early results. This is not published yet, but from the survey of patients, you can see that there's more agreement about the things at the top, the positive attitudes towards AI being used by healthcare to help them improve quality, AI used by healthcare workers to help them save time and cut costs. And people seem to agree that the benefits are greater than the risks. But at the bottom, there is concern about data being kept confidential, data sharing, and concerns about bias and relationships as well. In the next slide, we show the results about asking providers about a number of use cases. So we went through things from like lab and pathology summaries and chatbots and image reading to things like claims review, automatic claims review, and automatic prior approval submission and review. And we wanted to see what providers thought about these different kinds of use cases. So this was a virtual expert panel. So our results kind of coalesced into three categories. For image reading and ambient documentation, so two examples, clinical examples that we talked about, the respondents were most positive about their impact, their scope of use, and the opportunity for integration. They thought those were all positive. For some of the others, they were concerned that while they were potentially promising, they had less confidence in one or more of these areas. So you can see for like automatic claims review, there was concern about it having an impact on patients and providers. And for chatbots, there was uncertainty about how easily it would be integrated and other things. So some uses gave them more pause. Okay, we can go to the next slide. And I do want to mention some ethical concerns as well. So there could be a whole talk or a whole conference or a whole, I don't know, on the ethics of AI in healthcare, but I just want to highlight a few concerns. There's, safeguarding their information. There's cybersecurity issues, there's disparities, equitable access, and then also making sure that the AI isn't biased itself, and then informing patients that we're using their data. So I think it's the next slide, Jonathan. Informing patients is a major source of conflict. Some people say, of course, we should tell patients when we're feeding their data into an AI tool, whether it's to build the model or to make decisions about their care. But other people say we've been using versions of predictive models for years, and we've using, built on patient data, and we don't tell them that we're recommending a screening because the rule was triggered and we got a reminder in the EHR. We just tell them they're overdue for a colonoscopy. We don't announce that it's AI. So what should patients know? And this recent paper added a twist to that. It found that patients, in fact, were more satisfied with those messages written by AI and that they were longer and friendlier. But when patients were told that AI was involved, their satisfaction went down. So how do you notate that message? Do you say supported by AI? Do you say drafted by AI? Do you say, and how much is the provider versus AI also? So if we go to the next slide, there are differences by different institutions about how they approach this conundrum, some of them preferring transparency and some preferring efficiency or satisfaction, which one would hope would not be in conflict. So here the Health AI Partnership co-lead said that the FQHCs are sharing more about this than the corporate sites. Next slide, please. And then there's data security and privacy. We don't have a ton of time, so I'm going to go very quickly through this, but we did a study looking at the impact of ransomware attacks against hospitals and found that it increases not just, doesn't affect just what's going on in the hospitals, but a 15% increase in emergency department visits in nearby facilities. So ransomware and cybersecurity affect the whole system, not just the institution that's targeted. Let's go ahead, Jonathan. Next slide, and we'll go to the next slide. That's part of the ransomware. So basically, it's clear that technology can help clinically, that applications range from administrative to actual care with increasing risk from simply administrative to actually making clinical decisions. Next slide. And so what are the implications? So Cutler et al., who's, as you know, a famous economist, went through some of the impacts of AI. he said that it could substitute for routine office work, such as billing, appointment scheduling, and facility management. It can complement clinician work as opposed to replacing it, but potentially could replace office staff. And it could lead to development of applications that can have care delivered in cheaper settings, so places that don't have hospitals, for example, and enhance delivery of care by reducing biases and errors, potentially, although it may also introduce them, and identifying novel treatments for specific subgroups. So if we look at this just came out from the New England Journal. So looking at these different kinds of applications, what's ready and what's not. Again, the things that we talked about, patient education and claims processing, these are low risk. So those are near-term applications or things that are already being used. Actual medical diagnosis has a risk of misdiagnoses. So those may be more medium-term applications. And then longer term would be actually virtual health assistants or allowing these apps or these bots to make decisions, and there's a higher risk of wrong treatment. And so those would be longer term applications. So next slide, a way to frame this for the workforce. So AI can be a solution to workforce issues, but will there be negative impacts and can they be mediated? So just thinking about how it will affect the workforce, I think part of the reason that David Cutler was generally optimistic about people being replaced and not cut is that even if AI reduces the time spent on something, on appointment booking or something like that, front desk and support staff are still very overwhelmed, and we have shortages of lots of these folks. So the idea that they're going to suddenly lead to mass firings, I think is low risk at this point. And the freed up staff can be assigned to higher value and important tasks like helping patients navigate the system or managing more complex things like referrals or test results. Also, AI systems still need oversight. The staff are needed to monitor these things, to audit and correct errors, manage edge cases, and I hope that we don't lose people before we have all of those things taken care of. And of course, patient satisfaction and equity efforts require a human touch, so those aren't going to be replaced by AI. Not all patients are comfortable or successful with AI systems. And lastly, these workforce transitions take time. So even if there are things that can be replaced, it will take a while before a whole system is retrained or reassigned or changed. So just to end with the policy environment. So as everybody's aware, the recent election has caused a lot of uncertainty around AI policy. The first day of this new administration was included revoking the Biden executive order about AI. And so if this is a retreat from federal regulation of healthcare AI, it's important to look at what the states are doing. And this is going to be very important because if data and privacy and security are run by states and these other topics are run by states, then things will vary state to state. It will create a complicated regulatory environment for AI. It may be hard to predict, and it may be hard for industry, but here's a selection from David Blumenthal's recent paper about what the different states are doing. And he concludes, regardless of what happens, it seems likely that the producers and users of AI will confront an increasingly complex regulatory environment in the short term as federal, state, and international policy evolves. So that's something that we're watching very carefully at RAND as we think about policy recommendations. So I'll stop there and we'll open up for questions. I already see one in the chat. Thank you very much for your time. So the first question, Xiaochu, do you want me to just read it or do you want to present?
Yeah, it's actually my question. I have this opportunity to ask first. So you have mentioned that access to health is an issue. So could you please discuss how AI usage can increase access to care and therefore address the health workforce shortages by keeping patients away from the hospitals or away from the in-office care?
Yeah, I mean, this is something we've been looking at since telehealth. This isn't just AI. So is telehealth increasing access for people in remote places where they don't have physicians, or is it going to increase use because people can get on their phone or device and ask for more visits than they might have if they didn't have to go to the ED. And that's some of the work Jonathan quoted that Ativ Mehrotra and Lori Usher Pines have looked at. So those are still open questions about what the overall impact will be on use, but it definitely increases access, at least for the population that has internet. So there may be disparities in who has access, but there's a lot of evidence, especially around mental health, that mental health is delivered very well over telehealth, and there's shortages, and so it makes it possible for people to get it from their homes, people who have transportation limitations, and it's kind of surprising how many things can be delivered by telehealth. We just had a paper out on telepalliative care. You might not have thought of palliative care as something that goes over telehealth, but actually a person can stay at home. They're not very mobile. They can, it's really about expectations and planning. It's not about a physical exam. So that's actually something that has been very successful over telehealth, when the caregiver can make that possible and when the technology is possible. That's less about AI and more just about technology access. I think AI can help with some of the replacement of the actual decision making, which is more risky, but has also great potential. So then there would be no human at all there. So for example, some of the mental health tools that Jonathan was talking about. Jonathan, do you want to add?
Yeah, I think a lot of the discussion, at least that I've seen early on, was mostly focused on things like recommender systems of doing a better job of trying to reduce friction in terms of identifying a provider that has an open slot and being able to get in or apply for an actual appointment. I think that's been the one area that I think there's been a lot of optimism about that you'd be able to identify the provider that best fits your needs and that does have an appointment available. So it's those types of pieces that I think initially might help the most with access to care.
Cool. So when I think about AI and the health workforce, I always think about what the economist Robert Solow said famously in the early 90s. He said, you can see the computer age everywhere, but in the productivity statistics. And I was wondering, have we started to see AI impact on the workforce or work health providers' productivity statistics yet? Or do you think we're not going to see any?
I don't know of any research that's found that as of yet. I think there's always just inherently a data lag. And so even trying to identify who was using this was kind of a complex and difficult enterprise. I think, if there were funded studies to do so, it'd be very difficult, but it'd be worth doing is to try and either via survey data or just trying to see if they can use any sort of administrative data to try and see. But even identifying that reduction or increase in efficiency was difficult for telehealth, right, as well. And I think it's still being done. So I think, we could maybe use some of the methodologies that we've done for telehealth, but even that is still an outstanding research question that hasn't been answered.
And I think this is a bigger labor economist kind of question. I mean, we've been saying that since oh, now we have dishwashers and washing machines. What are we going to do with all our free time in the evenings? And so, what's happening? How does technology not increase, free time, and what are we replacing it with? And as medicine is getting more complicated, so are we bringing in the technology, but it's needed? And also, what does the financial incentives create such that the goal is not to stay where we are and be more efficient. It would be to then do more procedures or bring in more patients. And, to what extent is there an unmet need in the U.S. healthcare system or desire for, again, more procedures that would drive us to keep increasing, even if the technology might be able to, increase efficiency. So I don't know of a specific study on that yet, but those are good questions. I see that David Armstrong is asking about training on AI, and I think that's also a great question. I know that medical schools are starting to do that. I don't know of any formal curriculum or best practices, but obviously it's something that doctors have to face and that people are being trained on in different environments. In medical school, people focus that, you have to take anatomy and you have to take pharmacology. And there's been talk over the years about what's more important. Should people be learning statistics? Should they be learning health policy? Should they be learning health business management if you're going to have a practice? And I think AI is now on that list of things that are really important for people to understand. I mean, there's research that shows that doctors don't really have a great grasp on statistics unless they have further training. And so their ability to interpret the results of medical studies may be not exact. And so that risk is also there for getting answers from an AI system that's a total black box, not knowing what it's based on and not blindly following it. So I think that's really important. And I don't think that has been standardized yet.
I see there are several questions in the Q&A box. So the first one is, many of the shortages of the health professionals described are greater in the rural communities. What are the implications for smaller or rural healthcare systems and access or lack of access to AI?
Yeah, I mean, this was highlighted in the debate between voice only, like audio only, versus audio and video telehealth, and whether policy should reimburse audio only calls. So the argument for would be, well, there are people who don't have broadband. Shouldn't they be able to get access to their doctor over the phone? And the argument against is that's lower quality care. Why should we be paying for a phone call and allowing somebody to get this lower quality care when really the standard would be to have the video included? So I think this is not just a healthcare issue. This is a systematic access issue to broadband and to technology, and there are still disparities. We have shown that their disparities are getting better about people being able to access telehealth. So communities where, it's been education level, race, age. So those communities that didn't have as much access to telehealth has definitely been increasing. So AI is sort of, again, what does it mean to have access to AI? It would be access to all of these tools. So I think it would be really dependent upon broadband, and to the extent that the federal government is helping to make that possible versus not is going to be a big factor.
And we can move on to the next question from Michael. Given the old maxim that since computers cannot be held accountable, then they should not be allowed to make management decisions, what are your thoughts on the ethical implications of AI's use in healthcare decision making?
Yeah, so this is a huge question. And this is not a new question. So we've had clinical decision support for many, many years. And the clinical decision support, people, you get used to it. Like I click here, and you sort of automatically click and you say no to make a window go away. And this is going to pop up. And then when people shift from one EHR system to another, if the rule is not there anymore, it's been shown that they kind of expected that the EHR system would catch them and stop them from prescribing things to pregnant people that they weren't supposed to prescribe. And now they don't really remember that list anymore. They just kind of look for the alert. So that's definitely a risk. Same thing with AI. It can make suggestions, but ultimately the physician is responsible for anything that they do. And then, at what point, again, that brain plus a computer, at what point do you rely on it? And what point are you not able to rely on it anymore? But the overall accuracy and the speed is really impressive. So the ability to help physicians when they're going to get something wrong versus make them do something wrong when they were going to get it right. I think that's really, it's more likely that would happen right now. We're at an amazing inflection point where these tools are very powerful. But yeah, ultimately, the human has to be responsible. And then a question about negative impacts to low-skilled workers in hospital systems. Yeah, I mean, there's still this trade-off of maybe AI could make them be able to do more than they could do before. It could enable them to take on additional responsibilities, and also you're never going to have AI, or maybe maybe, but not yet, replace janitorial staff, food services staff. I mean, there's a lot of in-person requirements that are needed at a hospital that AI is not going to replace. So those kinds of workers are going to be needed for a long time. Do you have additional thoughts on that question, Jonathan?
No, I do not. I think you handled that one well. I do know the next one that there is questions about are they more AI is being currently used more often in mental health care or other areas of healthcare. I have to say there is a shockingly limited amount of research here right now. I know there is, at least some of the research that I had spoken about was just mostly like surveys that have been fielded or just some like preprint data. And so we had tried fielding this question at least for kids, just because we thought it'd be an area of interest. But I think, without having more aggressive asking of questions, we won't really know. I know like the best corollary that I saw, at least for even existing questions about healthcare use, was things about whether or not you use WebMD to diagnose something. And so, like, I don't know if that's the best type of questions we should be using, but there should be like a greater data collection approach that's holistically trying to understand who are using these tools and what are they using it specifically for. Is it for physical health? Is it for mental health? And then how often they're doing it. That's mostly just a researcher gripe that we don't have enough data. But as Shira demonstrated, we're doing a really good job of collecting data, at least for businesses and hospitals.
And specifically about the mental health, I don't know that I wouldn't say that it's being used more because there's many more non-mental health visits, but when there was a drop in in-person visits and the increase in mental health and physical health virtual visits, we know that when the bounce, it sort of came back to in-person visits, the mental health telehealth use stayed high. People are now very comfortable with mental health therapy, couples therapy, talking to the psychiatrist over video, whereas there was a concern that the in-person, that the physical health would be not reimbursed if it were not in person. So many institutions were pushing to get people back in person. A lot of that had to do with the policy environment and the sort of unknown about what was going to be reimbursed. And Jonathan alluded to this earlier. There's, this deadline keeps getting kicked down the road, and without knowing definitely what is going to be paid and what is not going to be paid, it's difficult for institutions to make informed decisions about, what kind of visits to offer to people.
All right. I think that will be our last question. Am I missing anything? And thank you so much, Dr. Fischer and Dr. Cantor, for sharing with us your insights and identifying these very recent evidence and studies in process before publishing, giving us these scoops. We appreciate you taking the time to be here today, and thank you for everyone who joined us today. I hope you enjoyed this discussion, and have a great day.
Goodbye, everyone.
Thank you so much.